So Ian asked me to talk about lies, damn lies, and statistics. I don't consider myself in any way a statistician, but we have spent quite a lot of time working with this database and trying to turn the database into useful outputs of various descriptions. And I just wanted to go through the stages and the processes in that, because I think everybody here has collected data from having done operations and put it into a computer locally, but the various stages which happen between that and getting something either into a high-quality scientific output or indeed getting something into the Care Quality Commission website as a sort of governance portal has a whole series of steps. And as we well know now, those steps can go wrong. And I just thought it would be useful to sort of articulate that a little bit. So all of this work has been done by Graham Hickey, who's sitting in the audience there, who's working now with us on the SCTS database. He's a very clever statistical analyst and also very smart with the data processing issues. So in the last 6 months since he took over working with us, we've made bigger steps than we've made in the last 15 years, in my opinion. So a lot of the work that's been done here and that we'll present through the day has been done by Graham and another colleague, Stuart Grant, who's a junior surgeon in Manchester. So the database suddenly has got just under 450,000 records. And we have to clean that, and I'll describe what I mean by cleaning as we go on. There's 181 fields which we use from 45 hospitals. So there's quite a lot of stuff going on. And it's all collected in different hospitals on a variety of different local software systems. And you have to clean the data. It's messy, there's measurement error, there's conflicts in the data, and we have to resolve those conflicts to make any sense of it all. So this just kind of describes the various steps going through from getting an extract from the Central Cardiac Audit database through the various things that we do to it before you get a final extract. And I just want to sort of point at some of those various steps to demonstrate how things can go wrong and what we do to try and prevent things going wrong. So we are bound by data protection legislation, and data protection legislation is a very important thing. If we fail on data protection, we will go to prison. So everything in the CCAD and everything that you collect on your database and then gets transmitted to the Central Cardiac Audit database has to comply with that legislation, which means it has to be encrypted. And that's good. It protects the patients, it protects us, but it's bad because actually the process to extract that data is quite complicated. So when we extract the data, it takes 1/3 of a second per record, which basically means if you're taking out 450,000 records, that's quite a lot of seconds. And that can fall down in terms of the computer systems to do that. And actually, because it's easier to do it by a person extracting at the other end and submitting us data, that requires them to do that. And we had a situation, and I just want to give some examples of where this messes us up, where Graham and his colleagues programmed some fancy stuff up about a BEMA-SEMA analysis, which we'll show a bit later, and all based on the data set that we got originally. They then give us another data set where they truncated the string field for the graphs. So all our programming was looking at a new string, which didn't make any sense. And that took us a couple of weeks to work out what was going wrong. And when we worked out what was going wrong, we then had to fix it, get a new extract, and make sure our software looked at that right string. And that's all fixed, but the concern about it is if there is a truncation of a string like that, and that leads to an analysis, and you don't know that there's a problem. So getting reproducible extracts has been a key for us in terms of making some progress on this stuff. And then I just want to talk a little bit about string cleaning. So what we mean by that is that some of you collect data on dendrite systems, some of you on Tomcat or local bespoke software systems, and there's a whole bunch of different options. So even if you just look at something like gender, are you a man, are you a woman, that should be pretty simple to sort out. But actually what we've got is a whole series of options. So what Graham has done is he's programmed all this up. So anything which is obviously a man, one.male, M, male, all that kind of stuff, we map into male. But if there's things which, and the same for female, but actually if they don't make sense, so 3 is not an option. You may have your views on what 3 might be, but 3 is not an option for us in the data set. So that maps to missing, or if there's a conflict to male, that maps to missing. So this is now an automated process to get the data sorted out. This might sound very mundane, but it's absolutely essential to actually making sure your extracts make sense in the end. Duplicates is another issue. We had one hospital who every time they re-uploaded their data to CCAD, it created more and more duplicates. And when they looked at those duplicates, they found there was a problem, so they re-uploaded it again, and it was just getting built duplicate upon duplicate. And that again can be quite complicated. And unless you're careful, you would have somebody who, for example, had a coronary artery surgery in the morning, who then had a problem with a graft and went back to theatre for that graft to be revised. And if that was taken out as a duplicate, that would be misleading. So we've produced a number of rules to actually detect those duplicates, which are based on procedure, urgency, and the number of previous cardiac operations, some other things. And this is all now written down, so if anybody wants to look at it, they can look at the logic, which is written down in English for people to see, or if they want to, they can look at the statistical code, which actually describes how this stuff works. We then have to create a series of flags to enable us to interpret the data, and what I mean by that is, and this is just looking at mortality a little bit, there's two different fields for mortality in the database. One is discharge destination, and one is status of discharge. So status of discharge is alive or dead. Discharge destination, one of the options is not applicable, patient died. Some people took a local view on that and put in another version, died late, which again we had to clean out. But again, what we've done is a series of logic based on those two fields to enable us to give a flag, the patient is either dead or they're not dead. And unless you do that, you get things horrendously wrong. What we also have is that dead flag, but we also have tracking from ONS data. So if that data for alive or dead is missing, we can back populate that using the ONS data, depending on whether the patient's died during that spell of admission. So again, using these various different fields, we try and populate as much of the database in a robust way so that we can actually then crunch the mortality analyses on it down the line. Another example is redo status. There's two fields for redo. One is a number of previous cardiac operations and one is previous cardiac surgery, yes or no. So we combine those to have a redo flag using the same kind of logic. We then get a final extract, having gone through all this kind of stuff, done some risk scoring on it using the various different risk models to have a final extract which we can then apply for governance analyses or we can apply for academic pursuits. And this stuff is absolutely essential, and now I think it's in good shape. So I just want to give you a sort of flavour of where things have gone wrong and what we've done about it. We found one hospital that actually were regarded to be a very good hospital and had historically very good mortality rates. And when we started to look at this in detail, we found that every time they did a cabbage and they put a balloon in, either before the procedure or after the procedure, their local software mapped that procedure from a cabbage to a cabbage plus other in the data set. So all the patients they had done cabbages on who had a balloon pump were taken out of analysis of isolated first-time cabbage. This wasn't in the rules. It was, I don't think it was gaming. I think it was an innocent oversight. But it meant that these analyses were wrong for that hospital. And we eventually found that out, somewhat by serendipity, actually, and we've now fixed that problem. But discovering these kind of little glitches is sometimes, has been in the past a little bit more of an art than a science. This is another example in terms of how you deal with cabbage plus re-exploration. If we do a bypass graft and that patient goes back to theatre for bleeding, we then put another record in our database, in the operative database, which then gets uploaded. So that would appear as two separate operative records in the database. Some hospitals, just if the patient was re-explored for bleeding or anything else, would just put yes in the database. And when you then have a patient who's had an operation, then gets re-explored, there's two records, and if that patient then dies, you have a yes dead flag against those two records. So what obviously you need to do is resolve that in a sensible fashion. Another example is if you have a patient who's admitted for a cabbage, who then gets an aortic dissection from the aortic cannulation site and then has to go back and have a dissection repaired, how do you deal with that in terms of attributing the procedure and mortality of that procedure? And what we do with that is we map all patients into the operative spell, the hospital spell, and we attribute the mortality to the first procedure in that spell. And again, Graham's coded all that in a sort of a rule-based kind of fashion. One of the problems with that is if the patient should come in on a date, have an operation on a date, go home on a date. But sometimes those aren't in a logical order, and then we have to make some clever rules about how we do that. But what we need to do is keep all the procedures in, because we don't want to be losing procedures because the date logic is not right. So this just gives an example of how things can look. So this is a local tale, but I think it makes the point. I'm crunching some numbers and doing some funnel plots about sort of governance for all cardiac surgery after adjusting for risk. And I keep a fairly careful handle on what's going on with mortality in our hospital, obviously, because I'm interested in these things. And when this initial analysis came back, we were one of the dots, we were this dot here, which was had a mortality rate, which is risk-adjusted mortality rate, which was higher than expected. And I knew our mortality rates were not bad at all. And I thought what had happened in the sort of couple of years since we last looked at this is everybody else had got spectacularly good, and we'd been left behind. So I went and I sort of dug into that in more detail to try and find out where the problem was. And the problem was with our isolated valve data. I dragged all the notes on the patients who had isolated valves and went through them all to try and find out if there was a common theme that we could learn from. We then had a discussion with Graham, and what we actually found was, I can't remember whether it was rationalising the duplicates or the attribution of mortality, but actually we had got it wrong, and we then changed the algorithm to actually look at it in the right way, which brought our mortality rates down to be just about average. So again, these very small differences in terms of the rules can make very big difference in terms of how you appear on a governance process. And I made that error being the person who is closest to the data. So you have to be very careful. This is another example. We were interested in looking at mitral valve repair rates for degenerative valve disease. So we filtered the data on valve pathology, and then we counted the number of operations for degenerative mitral valve disease and the proportion of those which were repair rather than replacement. And one hospital who were proud of their mitral valve repair program and their records didn't look very good in that analysis because they didn't collect any local data on valve pathology. So we can only analyse what we can analyse. There's a prescribed data set. They opted not to collect that data set, and therefore they didn't feel they came out well in the data set. So again, that was a local problem as far as I'm concerned. They made a judgment about what not to collect, and actually that had implications to them in terms of the way these things came out in the analyses. And I guess this is probably the most significant thing that we had. Dominic Pagano's not here, but he won't mind telling me that we were working together on this one. He's got a colleague called Nick Fremantle, who's a very clever professor of biostatistics, who's in Birmingham, now University College, and they were looking at the on-pump, off-pump stuff. And this is before we were quite so sophisticated in our understanding the data flow. And what happened was, in the manipulations required to do this after the stuff came out of the database, they truncated the data set. And they then created a flag variable for the treatment option off-pump, on-pump from what they had there, which wasn't quite right. And then they produced some outputs which suggested that off-pump mortality rates were higher, and these passed our initial sense checks. So a failure of data manipulation led to a analysis conclusion which was completely wrong. There wasn't a problem with the statistics, there was a problem with the data management process. But again, we asked Graham to have a look at it with an independent set of eyes to try and work out what signal there was there, and when we came up with a different answer, and at that stage we understood what went wrong. Look back in it, we understand it better now, so it won't happen again. But that's kind of my last cautionary tale, I think. So we have this rules-based approach to managing the data. That's all published online. The link's on www.scts.org, and it's actually on Graham's personal pages at the University of Manchester, because this is an evolving thing and a changing thing, so we like to keep that fresh. We have returned all this data recently to the units for validation in terms of the activity of rates for the various procedural groups, the incidence of risk factors, and also for mortality rates. And all the feedback that we've had from that has confirmed, I think, that our algorithm for doing all this kind of stuff is right, but we have picked up some local issues about local data which we've managed to resolve, and people understand that better. And then in terms of doing these validation, and this I guess is learning from these things which went with the off-pump thing, is that we now, when we're doing anything like this, we need to have very clear flow charts of data processing issues, independent sense checking of any analyses, and we're working through a formal accountable process for managing the scientific outputs to come from the database. So that's, I think, what I have to say about databases. There are obviously a whole bunch of statistical type issues and different strengths of registry data versus randomized trials, which I think Professor Wechsler will come on to in a moment.
Thanks very much, Ben. I think, does anyone have any really pressing question for Ben, or shall we wait till we have a more open discussion later? Any particularly pressing question? No. Okay, thanks, Ben. Okay, Andy? Brian. Are you? Sorry, don't worry.
So I think you heard a very elegant description of what's behind the scenes of a data set when you look at the output in the form of a published paper or comparisons that emanate from a database. Lies, Analyze, and Statistics, that sometimes has been attributed to the American author Mark Twain. That's argument, you can discuss that, but he certainly said, get your facts first and then you can distort them as much as you please. And oftentimes that's the game of statistics. And I'm going to speak to you from the viewpoint of who I am, which is sort of a bozo cardiac surgeon, not a biostatistician, trying to do what you do every day, which is to read an article and figure out if I want to apply the results of that article to my practice. Do I believe what's in there? As you know, the guidelines are based on high-level clinical trials, and there's a hierarchy of what we accept as best clinical evidence to worst clinical evidence. The worst clinical evidence being my case yesterday didn't turn out so well, so I'm not going to do it again that way. And the gold standard are randomized clinical trials. And these you're familiar with. These are usually large, highly powered studies that have the weakness, oftentimes, of being focused on a single outcome variable or a composite endpoint, even though they generate tons of data, which are frequently extracted in post hoc subgroup analyses that are then presented to you as though those analyses have the same validity as the original randomized clinical trial. So you must be on the alert for these subgroup analyses that require very complex statistical methods to determine whether or not they are reasonable. One of the problems with randomized clinical trials is that because of the nature of their inclusion criteria designed to eliminate most of the variables that confound other sorts of studies, is that the inclusion criteria in such trials may be extremely limiting. And about 10 years ago, when there was lots of furor over the early PCI versus CABG studies, a variety of studies were published which showed either PCI was better or CABG was better. Most showed that PCI was better. The problem was that the randomized trials that were quoted looked nothing like the real world. And perhaps in any given patient population, only 5% of the patients in that population, in fact, would have qualified for inclusion in the randomized trial, but the outcomes of the trial were considered to be generally applicable to all patients, even though they did not fit the match of the clinical trial. Now, when Mr. Bridgewater goes about analyzing the data from the registry, he's going to have to do a lot of work to try and make very disparate data sets have commonality that he can compare. And prior to a number of years ago, this was done by a case match series, which was a rather informal way of taking one group of patients and finding another group of patients who kind of looked like that group of patients, all data having been collected retrospectively, and then comparing the outcomes of these two groups and trying to draw a conclusion. Today we use a propensity analysis, which is a very sophisticated statistical tool for trying to match patients in one population with patients in another population based on a series of characteristics or variables that are defined. And that's where the danger lies. So this is, in other words, sometimes you look at a data set where there are 7,000 patients, a propensity analysis is done, and you end up comparing the outcomes in 353 patients of the 7,000 patients, because there was so much discrimination applied that most of the patients were eliminated from the analysis. Or alternatively, this looks like a perfectly reasonable study. It was a retrospective, as all propensity analyses are, study of bare metal stents versus a paclitaxel drug-eluting stent. And in the propensity analysis, you can see, is shown up top, that there appears to be a substantial mortality difference when these are used for the treatment of acute myocardial infarction. And on the basis of that study, a large prospective randomized trial was initiated by a pharmaceutical company. It cost millions of dollars. On the other hand, if you look at the first curve, it's apparent that there's no logic to the outcome here. you can see that almost all the difference between drug-eluting and non-drug-eluting stents occurred in the first 30 days after surgery, a benefit that no company claims drug-eluting stents are designed to produce, and they stayed parallel thereafter. In the prospectively randomized trial that occurred with many, many more patients in it, you can see that the outcome was absolutely identical between the drug-eluting stent and the bare metal stent, showing the danger of having covariables that are not accounted for in the original propensity model. If you want to increase the power of your observations, you collect a bunch of randomized clinical trials or observational studies, and you then do a meta-analysis on these. And you've seen these plots all over the place where, depending on the number of patients in the study, they're weighted in a variety of ways. There are very few meta-analyses that are able to match exactly the variables collected within the randomized trials that are included in the meta-analysis. And I assure you, as a reader, there's almost no way that you can dissect this out because it's so complex to look at the inclusion variables. So it's just a bit of a warning. And finally, registries. You're aware of this large syntax trial, and I think Mr. Taggart's going to be presenting data from it a little bit later on today. It's important to realize that when you do a randomized clinical trial and there's an accompanying registry that includes the patients that were not included in the randomized trial, that the patients in the registry may look very, very different from the patients who were actually in the randomized trial. As we said, that's one of the weaknesses of randomized trials in general, is that they tend to be rather exclusive. And so here you have an example where in the syntax registry, the patients look very different from the patients that were included in the syntax trial. The last point or two I'd like to make is what's significant. And I found this quote in an article. It's attributed to Anonymous. It says a p-value is no substitute for a brain. And you have to ask yourself, are composite endpoints reasonable? In the syntax trial, as an example, there was a failure to meet the designed endpoint, almost all driven by the need for revascularization. Should that have been included in the composite endpoint comparing mortality, stroke, acute myocardial infarction? How did revascularization weigh as an important variable? When you see a p-value of 0.005 compared with a p-value of 0.05, it doesn't really mean that the data are that much more meaningful from a biologic viewpoint. It may mean it statistically. It may be the consequence of a large number in one study, small number in another study, wide extremes of variable distribution in one study versus narrow in another study. And then, most challenging of all, can we equate statistical significance with clinical significance? And there have been another number of schemes that have been proposed to do that. So this is one, and it's a little bit complicated, but if you're designing a study, you're trying to determine whether there's a reduction or an increase in the odds ratio or the risk ratio of a particular intervention or procedure. And usually you define how great a difference there must be in order for you to consider that an important change from neutrality or fulfilling the null hypothesis. And that's sometimes called the minimal clinical important difference. And what's proposed here is, depending on the confidence interval of the data used in the study, and I don't think I'm going to go through all of these, it points out that you can have statistical significance, for example, in example C, where you have a very narrow confidence interval, highly reproducible data. But the difference between the null hypothesis and the clinically important variable that you defined as requiring a 15% change is so small that even though there's a statistically significant difference, it's of absolutely no clinical significance whatsoever. The alternative, if you look at example E, would be where you have a wide confidence interval. So the data is difficult to reproduce in the same precision. However, all of the data lies to the left of the clinically important sign here, 0.85. So here's an example where you have both statistical significance and a high probability that these data have important clinical significance. So these are just a few caveats as one goes ahead and looks at data in our journals, including data from large registries. And maybe we can discuss some of these later on. Thanks.